No, and it's not seen very much in my country either. This is where I'm from in Cleveland, Ohio, and Rainbow Babies and Children's Hospital is just this complex of buildings over here. This is a group of hospitals that came together in 1866 to form University Hospitals of Cleveland, now Case Medical Center. I'm going to confine my remarks today to the spine because this is where the vast majority of the literature and the vast majority of the concerns exist. Now, I don't want to sit here and make you think I'm an expert on spinal tuberculosis because I am not. We just don't see that in North America. The cases that have been seen in our country are usually those that come from other countries who the family moves to our nation. But it's Mycobacterium tuberculosis. There are endemic areas throughout the world. It is a major health topic for many of you in this room. It's not so much for those of us on the front row, though. Anemia, increased SED rate, CRP, and now we have polymerase chain reactions can all help you make the diagnosis. However, as we've already said today, that MRI is better than plain radiographs in making the diagnosis. Now, there's some very distinct radiographic features, and there happen to be the exact same ones that we see in fungal infections as well. Hence, this is another reason for putting these two topics together and considering them as one, because the initial management and the surgical treatment can be very similar. But in MRI, we're going to see end-plate destruction. You'll see a paravertebral smooth-walled abscess, what Dr. Dormans had talked about before. MRI will also tend to show that you have multiple sites and not just one site that you may see on plain radiographs. And about 3 to 5% of people who have spinal tuberculosis are going to end up with a kyphosis greater than 60 degrees. Another significant percentage will have an acceptable kyphosis that will not be in this magnitude. If we do acid-fast bacilli staining on the biopsy material, which we've already talked about the importance of biopsies today, they'll be found in about 25 to 75% of the biopsies. CT-guided biopsies can be obtained, and sometimes, and depending on the location, these can be very helpful. But they also suffer from the problems that we've already mentioned today, that of getting an accurate diagnosis. Cultures can take 4 to 6 weeks before they are positive, so it's something we need to get the histopathology to try and help us make the diagnosis so that appropriate treatment can be started initially. Now, there's a recent article by Jane that's in JBJS, it's in the British Journal, and I borrowed a lot of his material in order to make this talk because it's a wonderful review article of where we are in 2010. So I would really have you refer to that article for a lot more details than what I'm going to be able to provide in this short talk today. This just shows you the example on the left illustration, the difficulty sometimes in using plain radiographs to make the diagnosis. You can see what MRI can do here. Now, this is the same patient, but there's a 20-year interval here, and you can see the amount of kyphosis. You can see the cord impingement that has occurred because of the development of a kyphotic deformity. Just another example of one from in the cervical spine, again showing you the importance of MRI. You can see the soft tissue mass. You can see the preservation of the disc space. You can tell that it's primarily the bone is the site of infection, and you can see the paravertebral abscess on the illustration on your right-hand side, giving you an example of what this can look like on magnetic resonance imaging, particularly the T2 weighted images. Now, treatment-wise, the current concepts of treatment have been outlined again in this article by Jane, that there's still a role for non-operative treatment. If there's no kyphotic deformity, no neurological deficits, then beginning 2 or 3 anti-tuberculous drugs is the treatment of choice. And I can tell you in my institution, if we had a child presenting with either a fungal infection or with tuberculosis, we would use an infectious disease consultant to be with us to aid in the selection of appropriate antibiotics or anti-tuberculous agents and to help follow the course of the disease. Certainly Isoniazid, Rifampicin, Ethambutol, and Pyrazinamide are still the treatment of the agents of choice in today's society. Now, operative treatment for tuberculosis, typically if there's a deformity, if there's neurological deficits, if there is a fulminant infection in which there's a considerable amount of bone destruction, these are potential indications for operative management. And if we select operative treatment, we're still going to continue with the anti-tuberculous therapy, but then we have the choices of either anterior debridement, decompression, or corpectomy, and that's the decision that you have to make based on the extent of bone destruction and also any type of epidural abscess that may be present and the soft tissue abscess that may be anteriorly. All these individuals are going to require some type of posterior stabilization and fusion, and in today's world that's going to consist of some type of dual segmental spinal instrumentation with probably pedicle screw fixation above and below the area of involvement. This will correct both the kyphotic deformity and stabilize the spine from further deformity during the postoperative period, should hopefully allow the spine to heal in the most correct position. This is not without potential complications. Certainly neurological injury from the correction of the spinal deformity is a real concern, something you're going to have to be familiar with and do a very careful preoperative planning when considering this type of treatment. Spine fungal infections, also very uncommon, but we've had some experience with this in our institution, both in adults as well as adolescents as well. Typically, we're going to see these occurring in immunocompromised patients, and I would also say the same is true for tuberculosis in North America. People who are subject to getting tuberculosis are those that have some other health-related issue, either HIV, drug abuse, diabetes, they're on steroids, they're on chemotherapy for some type of malignancy. This does seem to be a factor associated with both tuberculosis as well as with fungal infections in North America. And I assume that's true for the rest of the world as well. The most common mechanism of spread of fungus to the spine is by hematogenous spread from the lung. They have very nonspecific symptoms. You have to have a high index of suspicion when making this diagnosis, but fever, malaise, back pain are common to both tuberculosis as well as to fungal infections. Neurological signs or symptoms are very worrisome when they occur because it usually implies that you have cord or nerve root compression. Abnormal laboratory studies are similar also than as with tuberculosis, the elevated white blood cell count, SED rate, C-reactive protein, and some of these organisms also have polymerase chain reactions that can also be very helpful in identifying which one of the fungi they may be. So again, high index of suspicion, one of the things that we probably don't think about doing is getting a travel history, but I'm going to show you a case in a moment of an adolescent that I took care of last year who had just been visiting in Arizona before getting his fungal infection. So where they've been recently, and when I say recently, I mean the last 3 to 6 months, can also be very useful in helping to determine whether or not that person's been in an endemic area for some of these fungal infections, and therefore that may be a consideration in your evaluation. Radiographic features, again, similar to tuberculosis. Disc space sparing, large abscesses are very common, the same things we just talked about before with tuberculosis. CT and MRI are the most useful. Plain radiographs are not particularly useful in distinguishing what the source of the infection may be. Biopsy, histopathologic assessment confirm the diagnosis, and we typically recommend that those be done early. The 4 most common types of fungal infections involving the spine are those from Candida albicans, Aspergillus species, particularly Fumigatus, Coccidioides immitis, and Blastomyces dermatitis are also the most common ones that we see described in the current literature. This is a review article on fungal infections, which I think helps to summarize, and this came from a variety of institutions which were able to summarize the data reflective of where we are in today's world as far as treatment of spine fungal infections. Non-operative treatment does play a role. This would consist of treating any underlying medical condition at the same time we're beginning antifungal agents. Again, the use of an infectious disease consultant should be mandatory for these because it's a very complex management, and I can tell you that from firsthand experience. Spinal immobilization in order to relieve symptoms is also important, but we want to keep the patients being ambulatory if at all possible, because keeping them up, keeping them moving, it helps to disseminate the antifungal agents. It also tends to help relieve their symptoms. Operative treatment, well, anybody who has spinal cord or nerve root compression requires decompression in order to stop the progression of the neurological involvement. Anybody with spinal instability who has a predisposition for having a neurologic injury is a prime candidate for surgical intervention. Deformity correction plays a role, but I think key to all this is to try and prevent deformity from occurring. So these are kind of the three more common types of indications. The fourth one is overwhelming infection. It's surprising the literature does support decompressing and removing a very large amount of fungal material from the involved site does seem to facilitate the penetration of the antibiotics, the antifungal agents into this area, which will help in the overall course of the disease. Again, options would consist of antifungal agents, anterior decompression with or without support, and then followed by some type of posterior spinal stabilization, usually some type of dual rod instrumentation that will span the area. If you have a lot of potential instability, you may do your posterior fusion and instrumentation first so that you protect yourself from catastrophic injury during your anterior procedure. This is my patient from last year. He had graduated from high school, had been visiting at the Christmas holidays in family members in the Phoenix, Arizona area, which is an endemic area for coccidioidomycosis. Began to develop fever, malaise, the typical features. You can see that the plain radiographs here don't help very much. T10 is one of the sites of involvement, which looks pretty normal here, except there is this very small soft tissue shadow, as you can see by the open arrow. Here we are with MRI giving you a more clearer picture of what is truly going on, and what this has actually revealed, as you'll notice, you have an abscess in front of T10. You can see the change in density that's occurring in the body of T10, but there's no spinal cord involvement in this particular case. Here's his axial view showing that it looks very similar to the one I showed you with tuberculosis, showing that he does have an abscess anterior to the vertebral body, but he also found that we had another lesion in L1, and you can just barely see the change in bone density as the sign of having an infection at this area as well. He was started on antifungal medications. His pain progressed. He was not doing well. This is just showing you another CT scan of what it looked like. You can see the CT shows this kind of permeated look on bone. And on the CT reconstruction, I want you to pay attention to this because this is what it actually looks like when you get in there, kind of this kind of punched out lesions with kind of vertical support areas going through the vertebral body. There's his bone scan, increased uptake at both locations. But as I said earlier, he was not doing well with his antifungal medication. He'd been in the hospital. He was supposed to start university the next month, and this is in August of 2009. CT scan, repeat MRI shows that the disease process has been progressing, as you can tell. So it tells us that the antifungal agents are not penetrating to where the active portion of the infection is. So based on this information, we decided that we should do something surgical for him, and this is what we did. We actually spanned over both T10 and L1, doing 2 vertebrae above and two vertebrae in the middle and 2 below the areas of infection. The response to this type of treatment was remarkable. Within a week, his pain is gone. He goes to university in September. I saw him back at his first month visit when he just came home from college. He felt like he had been cured. We did not do a complete corpectomy. We were in there, we saw this kind of collimation look, these small supports. The bone was very sclerotic and very dense. We were able to wash out almost all of the infected material. In fact, we left nothing behind. But we asked infectious disease if they thought that would be sufficient, or we were prepared to do a corpectomy at that time. They didn't feel that we needed to continue on with that because we had done such a massive decompression of the infected material. So anyway, he finished a couple of months course of intravenous antifungal medication, then was changed to oral. Here we are this past July, and you can see what T10 and L1 both look like on the axial views as well as the sagittal view on the left. with remarkable reconstitution of both vertebrae. Again, he is asymptomatic. His laboratory values have come back into normal. And this is what he looks like on his plain radiographs. And he's off to going back to university in a few weeks. Fortunately, it's close by to where we are. This is another article. This is from my institution, but this is from the late Dr. Henry Bowman, one of my partners who passed away a month ago. And he published in the Journal of Bone and Joint Surgery in 2001 on 11 adult patients that we had seen in Cleveland between 73 and 89, give you an idea how rare these things are. Their mean age was 55 with a range of 27 to 78 years. 10 of these patients required longer than 3 months had symptoms longer than 3 months before the diagnosis was ever made. 9 had neurological symptoms, particularly motor weakness, and surgical treatment was required in 10 of these patients. Complications occurred in everyone. 9 had 1 or more major complications, and 2 of these patients died, 1 in the first couple of weeks post-op and 1 about 3 months post-operatively. At a mean follow-up of over 6 years, the lesions had healed in those that survived, so all 9 patients that survived, they healed their lesions. There were no kyphotic deformities, and only 4 of 9, however, regained neurological function that had been lost. So most of the time when neurological function is lost, it's going to remain so. So what can I tell you in conclusion about tuberculosis and fungal infections? And this, again, is applicable more to children than adults, but the literature is so sparse on this that I included some of the adult literature as well. TB and fungal infections of the spine are uncommon, particularly in North America. Immunocompromised patients form kind of the core group in which are involved with either one of these disorders. Requires a high index of suspicion in order to make the diagnosis properly, and I think a lot of that has to do with the rarity of having this type of infection. They both have similar clinical and radiographic features. You need to understand the indications for both non-operative and operative treatment if you're going to successfully manage these individuals. And you can tell by the type of patients I've shown you, as well as from the literature, that these are fairly complex and the prognosis is not always great. Thank you very much.
Thank you very much. Any questions? Again, Mr.
I knew he was going to ask me a question.
I'm not going to ask you a question, but I'm going to add something. For tuberculosis, there is very one good saying that nobody is safe till everybody is safe. Secondly, when we are doing surgery in tuberculosis of spine without neurological deficit, there is one article, especially for kyphotic deformity, when we are feared that the person will develop kyphotic deformity, and for instability, there is an article, let the instability stabilize by itself. Don't hurry. You must wait for 3 to 4 months by giving anti-TB drugs and see the response. Give time for the spine to stabilize. What is happening these days, even in India? Patient of TB spine came, 1 or 2 vertebrae destroyed. After 5-6 days, take the patient to surgery, put a cage, and put metal posterior stabilization, pedicle screw and whatever they are doing. One of our very senior professor, he has said that tuberculosis of the spine, it is a local manifestation of a generalized disease. So don't think when you are taking out the tubercular material from the local side, you have eradicated the disease. It is a generalized process. So let the instability stabilize by itself. And in an adult, if 2 vertebrae are destroyed, I have more than 120 patients who are doing everything. They are doing full flexion, they are running, they are walking without any surgical intervention. Thank you very much.
Yeah, well, thank you for your comments, because you obviously have a lot more experience than many of us do. I know from my time when I was the deputy editor of the Journal of Bone and Joint Surgery, as well as my current role as the co-editor for the Journal of Pediatric Orthopedics, we've had a number of articles submitted talking about the reconstitution of the vertebrae and the predictive value, so that you don't have to just automatically go after them. I think the key thing about it is the neurological symptoms, and any neurological compression is probably more of an indication than the kyphosis itself, although preventing the deformity is one of the keystones of management of tuberculosis.
In children, the indications are different.
Yes.
When it comes to adults, because in children, the kyphosis may progress.
Right.
But in adults, the situation is not like this.
Any more questions? I'd like to thank all the speakers for their excellent talks in this difficult subject. Thank you very much, and thank you for keeping the time.